This card.
Good.
It's normal. P is here. It's not clear. Let's check another leads.
P is present.
Not clear. So this P and this P, this P and this P look different.
This is totally abnormal, no, sir. See?
It's the part of
They're different leads. So there is short interval of connection. Before this pause is longer than this one, so it is. This card is not very well. I will not give it on the control, but it's possible supraventricular extrasystole because of short interval of connection, long distance, and complex looks same like a previous one. Quality is okay. There is tachycardia. Next, we need to check size of QRS complex. QRS complex is small. It is narrow, so it is supraventricular tachycardia. Next, we need to check is the P wave or not. Is it P wave?
Yes.
Is it P wave?
No, T wave itself.
It is T wave. Look at another lead. So it is T wave. It is not P. P wave is absent. It is supraventricular non-sinus tachycardia. What is it?
It's a
Ventricular fibrillation.
There is tachycardia. QRS complex is wide and deformed. So it is ventricular tachycardia or fibrillation. Fibrillation is asynchronous. These are same, synchronous, it's rhythmical. All complexes are similar. That's why it is ventricular tachycardia or flutter, but not a fibrillation.
Excuse me, sir. Now from here, how did you say this is T and not P?
It's not clear, is it P or T? So look at another list.
P.
It is T. It is exactly T.
QRS.
T.
P absent.
P is absent. So this card M shape in the V1, V2.
L B B B.
S wave can be longer or deeper, but in this case it's normal. So these leads have a M-like shaped QRS complexes. It is
branch.
V1, V2 is right branch. The right leads, right branch bundle is blocked.
Right branch.
Tachycardia, it's clear. Complex is narrow. So it is supraventricular tachycardia. Same thing. It is P or T.
T.
It is T. So that's why it is non-sinus supraventricular tachycardia.
so we don't need to check the before we check the axis and then
Everything we did.
okay.
I try to save time.
Okay.
We have to go in.
Quality is
order.
okay. Rhythm is non-sinus tachycardia. Electrical axis of the heart, the register wave is here, which is levogram. M shape, QRS waves in the V5, V6.
Left.
Deep and long as waves in the V1, V2. Left branch bundle of his flow.
So at that point, shouldn't we see the presence of P wave and all?
Yeah,
We have to, right?
we have to.
P wave.
அந்த புக்கில் நல்லா எக்ஸ்பிளைன் பண்ணியிருக்காங்க.
It is QRS complex, ST segment, T,
P.
E.
Okay.
And there is also tachycardia. Sinus 1 because of P wave is here. So sinus tachycardia plus wide deformed complexes. Due to
அதற்கு tachycardia வரலன்னு சொல்றாரு.
அது கிட்ட 3.9 இருந்தா டேக்காடியா ஆர்ஆர் 3.9 இருந்தா டேக்காடியா
The ST technically is like
மூணுக்குள்ள இருந்தா tachycardia.
no, if there is heart block, if there is tachycardia, depression of ST segment, a little bit elevated ST segment changes of T wave are not ischemia. We don't know is it ischemia or not. It's not clear using ECG only. If patient have a chest pain, we can suspect ischemia and we need to do laboratory testing. But using using ECG in cases of tepanitis.
That's a micro.
Yeah, for myocardial infarction first of all. In cases of right or left branch bundle of his block, it's impossible to find myocardial infarction, to find ischemia, to find some another changes. So that's why differential diagnostic with ECG is impossible.
It's always in the V1 and V6, always.
V5, V6 is left branch, V1, V2 is right branch.
It's always combined.
Yeah. There is tachycardia, there is no isoelectric line between complexes. Tachycardia with narrow complexes, P waves are present. Sinus tachycardia.
So do you have a normal ECG?
For what? We don't need a
No,
normal.
I mean to compare.
This one is close to normal. But second lead is without P waves, but this one may be P wave, but no, P waves are absent everywhere. Except P waves, it is normal ECG. Is there arrhythmia or not? It's not clear. So just
If you clear the arrhythmia, we want full lead, long leads.
yeah, of course we need at least 3 complexes.
Then how we
Any
can
problem with it?
In this way, in this card, no way to identify
And
arrhythmia.
sinus, but we can't say the arrhythmia.
Yeah, we cannot tell it.
second periphery.
ECG, then you print out like this, right?
This ECG are from Hampton book, some ECG are from real patients, from our hospital patients.
Paitran, konjam priya.
Hampton book is better.
Board illa.
Easy.
There are made ECG made easy Hampton book. It is basics of ECG. These cards are from another book. There is book Atlas of ECG of Hampton. There are many different cases in this book. So tachycardia and complexes are wide ventricular tachycardia.
But that's non-sinus. No, there's no PV.
No PV.
So non-sinus,
Ventricular
ventricular
tachycardia is always on sinus. Pacemaker is ventricle.
CPR.
We need to do CPR. Yeah.
Patient name.
Tachycardia with narrow complexes. Supraventricular tachycardia. This wave is T wave.
T wave.
So it is non-sinus.
Ventricular.
Supraventricular.
Supraventricular tachycardia.
Fibrillation.
This place, everything is rhythmical. P waves are here. This
But
place,
this is actually fibrillation.
why atrial fibrillation? P wave is here.
But before like some long pause.
P wave. P waves is here.
Atrial block.
If there is P wave, it cannot be atrial fibrillation.
Oh,
These are artifacts. It's not nothing.
it's a medical.
Machine.
Easy block.
Here, everything's okay. Look here. There is arrhythmia. This distance is long. This distance is short. But this distance is shorter than this one. Look at P waves. They're present everywhere. So it is sinus arrhythmia. And it's written inhale. Inhale, which you asked. It is sinus respiratory arrhythmia. During inhale, patient have got arrhythmia.
So this is the inhale, this is the exhale.
This part is inhale, this part is normal breathing.
Oh, okay, we want to start here. So where's AVF and AVR?
1, 2, 3, AVR, AVL, AVF.
Okay. Yes, I repeat that here. Huh?
Normal. Respiratory.
AVR, Atrial.
I know na.
Advanced.
Why we want this?
Advanced.
Why?
Why we want this inspiration?
Every time when we register ECG, we do the registration of ECG in the normal breathing. Next, ask patient to keep inhale. And next, register ECG again to find
Maybe during
respiratory.
some patients they are register the exercise by doing some exercise.
It is another test. It is exercise testing. We do it to provoke arrhythmias or ischemia if we cannot find it in the simple card.
Doctor, why we specifically again take ECG in inhale moment?
To find respiratory arrhythmias. Sometimes inspiration can provoke arrhythmias, heart blocks, or something else. To find it, we need to ask patient to keep inhale.
Okay.
This card. There is arrhythmia. E waves are present everywhere.
Sinus.
So arrhythmia is with sinus pacemaker. Let's check next. If we will take this distance, we will able to put it twice here. So it is SA block.
Doctor, here also maybe 2 times, but
Yeah, but before we had a normal distance. This one is abnormal
Okay.
distance. It's shorter than
only in a normal we can compare.
So this distance can be put it twice here. That's why it is SA block. In difference from this card, this distance is shorter than normal. This distance is constant. This one is normal and repeat again, and again. You can go. Here. This case, where is wrong place? Where is wrong place? Yes, these places are wrong. If you can see wrong place from the distance, it is ventricular extrasystole in most of cases. Let's confirm it. Arrhythmia. This pose is shorter than normal one. This one is shorter than normal one too. After this complex, there is pose, which is longer than normal distance. And this complex is wide and deformed. This ventricular extrasystole. And also P waves are absent before extrasystolic complex. Ventricular extrasystole.
Doctor, in this case it is normal.
It's abnormal. It's an extrasystolic complex. Sometimes students think about these complexes like about myocardial infarction.
Yeah. I also.
Can myocardial infarction appear for one complex and disappear?
It's
Myocardial infarction is present for months.
Enamanda?
Myocardial infarction will be present in every one complex. It will not disappear. If it happened and disappeared, it is extrasystole. Extrasystole. Where is wrong place?
Yeah, extracurricular activities.
This place and this place. Same ventricular extrasystole. Complex is wide, deformed, differ from previous complex. So it is ventricular extrasystole. This one is interval of connection, which is shorter than normal interval. Extrasystole.
ventricular extrasystole.
This one.
Manti Pyron with the
P wave session.
Previous, but the distance between PQ interval is
This one.
yeah.
It is interval of connection. It is criterion of extrasystole. In extrasystole, distance between last normal and extrasystolic complex is shorter than normal one. And the distance after extrasystole and before next normal complex is longer than same wide deformed QRS complexes. This distance is shorter than normal one. P wave is absent. Ventricular extrasystole.
No, it's TV.
So what has happened here?
Extrasystole.
Ah,
Normal complex, different complex. Normal again. It is extrasystole. Tachycardia with wide deformed QRS complexes. Ventricular tachycardia.
Why it's not a fibrillation? Fear absorbed.
Fibrillation is irregular. We can conclude it like a flutter or tachycardia.
But flat.
Clinically, they are similar. This one is fibrillation. These complexes are regular. These complexes are irregular and everywhere different. There are no complexes here. There are visible complexes here.
Idanda fibrillation.
This is fibrillation. This is tachycardia.
Sinus.
சரியா வருது இங்க இந்த ஒரு order.
Regular.
I divide curves into types. Tachycardia. Complex is narrow. P wave is absent. Supraventricular, non-sinus, tachycardia. Tachycardia, 141 beats per minute.
sinus.
P waves are present.
So sinus.
Complex is narrow. Sinus, tachycardia.
Doctor, it's maybe M.
No, it is QRS complex, ST segment, and T wave.
T and P combined.
Look here. T, P,
It's combined.
combined. There is no pause between them.
Tachycardia.
This card is not for control, but on the exam you will able to explain extrasystoles here. Wide deformed QRS complex. It is extrasystole.
T. P.
Extrasystole is ventricular one. Extrasystoles appear every second constriction. It is bigeminy. Two normal, one abnormal. Two normal, one abnormal. It will repeat again, and again. It is Trigeminy. Three normal, one is abnormal. Every fourth complex is extrasystole. It is Tetrageminy or Quadrigeminy. This one, tachycardia with wide deformed complexes, ventricular tachycardia. But before, normal cut was registered. So we can tell it by word paroxysm. Paroxysm. Paroxysm means flare of something, sudden appearance of something. Paroxysm of ventricular tachycardia, sudden appearance of ventricular tachycardia. This case, extrasystoles. Every second constriction is extrasystole, so it is bigeminy. All extrasystoles are with abnormal shape, so it is ventricular extrasystoles, but different extrasystoles look different in one lead. It is polytopic extrasystole. In different cardiomyocytes generate new extrasystoles. So there are many different places for extrasystoles. Extrasystole, ventricular one. These round places are visible from the distance. Short interval, long interval after, complex is deformed. That's why it is ventricular extrasystole. There is arrhythmia, no P waves. It is atrial fibrillation. I mean, if you want, there is a free place behind. Arrhythmia without P waves. Atrial fibrillation. quality is bad.
So it's rejected.
We cannot continue assessment. Tachycardia. And let's check for P waves. It is T wave. P wave is absent. Non-sinus tachycardia. It's supraventricular one. And also there are signs of myocardial infarction. QS waves in the V1, V2.
Elevation.
Yeah.
Elevation in all the waves, right?
In the V1, V2, there is elevation of a ST segment and QS wave. So it is myocardial infarction in the anterior wall. Tachycardia with narrow complexes with a P waves. Sinus tachycardia. No P waves and arrhythmia. Atrial fibrillation. M-like shapes in the V1, V2. It is right branch bundle of his block. And also there is arrhythmia. P waves are here. It is sinus arrhythmia. M-like shape in the V5, V6. Big S waves in the V1, V2. It is left branch bundle of his block. This card on the exam is support to answer heart block. On the control I will not give it to you. Number A is SA block. Distances are similar. Next is twice longer distance. PQRS complex disappeared here. SA block. AV intraatrial block. Conduction inside of the atriums can be affected too. If it will happen, we will see M-like shape P wave. Similar like for left atrium hypertrophy. Differentiated by ECG only is impossible. We need ultrasound also. Next one, AV block, first degree. PQ distance is more than 5 cells, more than 0.12 seconds. AV block, first degree. AV block, second degree, Mobitz 1. PQ distance is close to normal, longer. Next P wave is here, QRS disappeared. Next P wave appeared again and new complex will appear again.
Like this.
This one. AV block, second degree, Mobitz 2. PQ distances are similar. P wave is here, QRS disappeared. And this one. Complete AV block. P wave has own rhythm. QRS complex has own rhythm. This place, QRS complex appeared after P wave. This place, before P wave.
Sometimes same together.
Yeah. Big F waves instead of P wave. This atrial flutter. Flutter.
FLUTT.
Flutter. Flutter. Even. Flutter.
Arrhythmia.
Flutter.
P waves are here. We can put this distance twice here. It is SA block. SA block. So rhythm was regular, here is irregular. So arrhythmical place is here. This distance is normal, this one is shorter, this one is longer than normal. Check for P waves.
Present.
Absent.
Okay, it's TV.
It's present, it's absent. Two complexes are with P wave, this complex is without P wave. So it is extrasystole.
Okay.
Because of P wave disappeared, it is extrasystole. This complex looks similar like a previous one. It is supraventricular extrasystole. In difference from SA block, this distance is shorter. In difference from the sinus arrhythmia. Okay, blocks. Arrhythmias are here. This place and this place look practically same. P wave is here, P wave is not here. That's it. Another person with myocardial infarction. Is it hard?
It is.
Yes, of course.